Our health system right now represents, as of right now, 20 hospitals, and probably before the end of the year will be 21 hospitals. It ranges from quaternary hospitals that do transplants and everything else to 4 more tertiary hospitals, which will probably be 5 before the end of the year. And then all the rest are either large or small community hospitals. We have 400 ambulatory sites. We have 2,700 full-time physicians on staff who are in the medical group, but we also have over 7,000, probably close to 8,000 voluntary staff. So we are a mixture of both voluntary and full-time staff, and that's at all of our hospitals. Some hospitals a little bit more in the full-time staff, but every hospital has a large voluntary staff. We do have 3 long-term care facilities, and we now have a new medical school, which we started 4 years ago, and this May is graduating its first class. We also, and they're going to have a special hosting them on public TV this weekend. We also have a large center for learning. We have a large corporate university and a simulation center. The main simulation center is a 25,000 square foot simulation center, which we use not only for training, but we also use it in our world of quality. When we want to test a new process, we actually test it in the simulation center. In addition, we have the Feinstein Institute for Research, which has approximately $45 million a year in NIH grants. And we just did an affiliation with Cold Spring Harbor, which is a large cancer research center, so that we could start doing phase 1 studies. There is a large competition out there to gobble up physicians, and I must admit my friends at the other major institutions and other systems in New York have been very successful in getting physicians. And it's not a matter of us gobbling up. Quite frankly, physicians now have really come forward asking to be part of a system because physicians want to be part of a system because they recognize they can't survive anymore as a onesie or twosie. They can't survive as a onesie or twosie because they need to be in this integrated network. They need to work through an IPA, Independent Practice Association, or need to work as a part of a medical group to get all the resources they need for what the contracts require for either risk or shared savings. They also need it because of the information exchange and being part of a network on that. Having a standalone unit doesn't really do them any good. So it really has put a lot of pressure on physicians to be part of a group. There's still a lot of onesies and twosies out there. And not every physician is really ideal, and we haven't taken every physician who's come forward to us. The hardest thing for physicians if they stay in independent practice is, number one, they have to have an information technology now. That's a requirement. So unless you're going to retire in the next 3 years or so, your Medicare reimbursements are going to go down. They really have no ability as a solo physician to argue about reimbursement rates with insurance companies. And the major managed care companies or health insurance companies are really looking for tight networks. And they want networks that can produce quality data. And they will narrow it down based on that. And if you're out there by yourself, A, it's hard to get the data. And 2, even if you can get the data, it's hard to maintain the quality they want when you're by yourself, when you don't have the ability to coordinate things. So if you're out of the office and the patient goes to another hospital emergency room, gets admitted, then you have another admission and you're dinged for it, so to speak. Whereas if you're part of a coordinated system, we have a call center, for example, where patients can call. We even have an innovative program now where patients who are either homebound or recently discharged, if they need they call up the physician and there's a concern, but they really don't sound like they need an emergency room and it's off hours, we actually send one of our paramedics from our ambulance teams to actually go to the house with a video camera. It's video linked. There's a physician on the other end. They examine the patient, talk to it, and it may be that the patient just needs some increased diuretics or something else like that. Patient avoids going to the emergency room. They're in their own house. And we do not waste resources because we all know when half of these patients come to the emergency room, they get admitted. It happens. It's very hard to get them home, and they wind up being admitted. And when many times that wasn't necessary. 2 years ago, the North Shore-LIJ Health System founded its own insurance company called Care Connect. As of right now, it's been on the Health Exchange in New York, and as of right now has 25,000 members. We expect it to grow next year even more. Because we have the premium dollars, we have risk, but it also allows us to put in innovative policies and innovative methodologies of treating patients that we can provide care coordination, which we couldn't before. And again, it's not that you have to do it for all 25,000. Most people know that it's a small segment of the patient population that eats up 50 to 75% of our dollars. So if you focus most of your effort there, as well as obviously doing the preventive care that you need to do, then you stand a much better chance of doing okay financially. And by having those new mechanisms around for patient care, you can translate and start moving them and expanding them to your other patient base. Because now everybody's learned how to do it. We have the money to, so to speak, pilot it and learn.